started.
All right. Hi, everyone. Welcome to Women Empowerment's shadowing session. We hope that you will enjoy today's session with Dr. Shanika, who will be discussing about ophthalmology. Thank you, Dr. Shanika, for joining us today. Whenever you feel ready, please begin your presentation.
Great. Thank you so much, you guys, for having me today. I'm honored. So I'll jump right into it. The title of my talk is A Doctor with an Eye for Eyes. And this title is actually from a book that I read with my toddler, which is about Patricia Bath, who is a Black female ophthalmologist. And it's just about her journey and how she paved the way despite the challenges she faced as a woman in medicine, especially as a Black female in medicine. And she was one of the first physicians to develop some of the laser technology that we use today for cataract surgery. So that's why I just thought it was appropriate to title this talk A Doctor with an Eye for Eyes. And I'm excited to talk to you guys about insights into my journey into ophthalmology. Certainly when I started as a pre-medical student, I never thought I would be in ophthalmology. So anyway, I'm a medical retina specialist and also a general ophthalmologist. I do cataract surgery. I'm based in Northeast Ohio. A little bit more about me. So I grew up in Northeast Ohio in the Cleveland area. My mom is also a physician. She's a family medicine physician, and she is actually the number one reason why I was interested in medicine. I grew up watching her build her practice. She was a family medicine physician in solo practice for over 26 years. So I watched her balance being a mother, being a physician, and a business owner. So watching her grow up, I kind of knew that I wanted to go the path of medicine. I initially wanted to be a pediatric endocrinologist, so very, very different from ophthalmology. When I was younger in middle school and high school, I had done research in diabetic retinopathy. I was really interested in science, and I had gotten this opportunity to work in this lab, and it just happened to be on diabetic retinopathy, which is actually another word for diabetic eye disease. From that started my interest in diabetes. It's a chronic disease, very, very prevalent in all age groups, and has many devastating medical consequences. So that's kind of what drew me to pediatric endocrinology when I first went into medical school. Then when I was in medical school, I realized I really liked doing procedures and wanted to do something a little bit more procedural based. So I thought about doing gastroenterology. And then after my third year rotations, I realized, and I actually did surgery as my first rotation, I realized I loved using my hands. I never thought I would love surgery, but I didn't like the surgery lifestyle per se. And so I started looking at other surgical subspecialties. And that's how I fell into ophthalmology. So first I'm going to go into a case presentation. So we have a 42-year-old female who was referred for a comprehensive eye exam. She came in complaining of floaters or squiggly dots in both eyes. These floaters had been going on for almost 4 months. They were in both eyes, but a little bit more in her right eye compared to her left eye. When she was younger, she actually had a history of poor vision in her right eye, and that's called amblyopia. She is otherwise pretty healthy, no allergies, no previous medical or surgical history. She doesn't smoke, drink, take illicit drugs. She works as a sales representative, and her family history, we'll touch on that a little bit later. So this is her eye exam, and eye exams can, when you haven't looked at them before, the way that we write our eye exams can be kind of intimidating. And in medical school, we really don't learn how to examine the eye in that intricate of detail, nor how to document a full eye exam. And that's really what ophthalmology residency is for. So OD versus OS. OD means right eye. OS means left eye, and that's at the top. Next line is visual acuity. So in her right eye, she could only count fingers at about 1 foot. So she could only see things really close to her face. Her left eye, she could see pretty good, 20/25. We consider really good or perfect vision at 20/20. Her pupils were equal and reactive. There was no afferent pupillary defect, which sometimes can be a sign of problems in the optic nerve if you have an APD. Her confrontational visual fields were restricted in her right eye, but they were normal in her left eye. We look at confrontational visual fields when we're assessing stroke patients. Motility, her extraocular movements were full. Her IOP, or intraocular pressure, was normal. It was 12 in her right eye and 10 in her left eye. We like to see an intraocular pressure of less than 21. Her external exam, her eyelids and face were normal. Anterior segment exam, that's when we're looking at the front of the eye. She had some whitish opacities, and I'm going to show some pictures in the next slide. She had some whitish opacities on the lens in her right eye. The left eye looked normal. Dilated fundus exam, or DFE, means when we're looking at the back of the eye. So in her right eye, she had a lot of clumps and debris in the back of her eye. And actually, she had some vitreous debris in her left eye as well. So that's just a breakdown of the eye exam. Again, can seem really intimidating at first, but over time you get used to the language. This is an ultrasound of her right eye. So this is the front of her eye, and this is the back of her eye, or her retina. You can kind of think of it like an ultrasound for a baby. So same technology, just smaller organ. And this is something we can do in the clinic. So in this, you can see this debris is what we saw in our exam, and it's right in the middle of the eye. This is a photo of her right eye. And if you're like, what am I looking at? That's okay, because it's really hazy because of all that debris that we just saw in that previous ultrasound. So all this debris is blocking the view to the back of her right eye. This is her left eye. She has a little bit of debris in the center of her eye and her vitreous in the left eye as well. But you can make out some details in her left eye. You can see her optic nerve back here. That's that little yellow structure. And you can see some of her blood vessels. So again, this is a really hazy view of an abnormal eye. This is sort of what we see when we look through the slit lamp or the microscope. And again, that's a learned skill during residency. This is a little clearer picture. So this is a picture taken right at the slit lamp. And this is what I was talking about, this debris in her eye, pretty large cause of floaters. So in terms of when in medicine, we always try to think of a differential diagnosis. So the differential diagnosis for her vitreous opacities, we need to kind of brainstorm. So there's a few big categories when you think of differential diagnoses for any condition in medicine. You can think of infectious, you can think of autoimmune or inflammatory, traumatic, neoplastic, and idiopathic, meaning we don't know why. So in terms of infectious, there's different infectious diseases that can present in the eye. There's a term called endophthalmitis, which is a term for a severe eye infection. It can be bacterial, fungal, or viral. Toxoplasmosis, Lyme, syphilis can also present in the eye. Other sorts of things that can kind of look like this in the eye that are related to autoimmune conditions are called parasplenitis. And that can also be associated with multiple sclerosis. And another inflammatory condition is sarcoidosis. Traumatic, so trauma, any type of trauma can affect the eye and cause bleeding or a vitreous hemorrhage in the eye. And once it's kind of old, it can kind of look like these debris or particles in the eye. Neoplastic, so lymphoma can also show up in the eye and look like this as well. And a common cause of floaters in the eyes is asteroid hyalosis. It's basically cholesterol deposits that can collect, again, in the vitreous in the eye. So lots of different causes for vitreous opacities or debris inside the eye. So like I said, we skipped her family history before, but now we're going to talk about it because it's pretty relevant. So she has a family history of familial amyloidosis. Her mom and maternal uncle are positive for the transthyretin mutation, which is one of the mutations in the um, under the umbrella of familial amyloidosis. It can affect your heart and your liver. So her family members had undergone cardiac and liver transplants. It can also affect your eyes. So it can affect your cornea. Amyloid deposits can accumulate in your cornea or in your vitreous. So her mom actually had to have a corneal transplant and a vitrectomy. The patient herself is also positive for the transthyretin mutation. She's been followed in an amyloidosis clinic at our hospital since the age of 30. She's had no systemic symptoms of amyloidosis, so no heart or liver problems at this point. So it's pretty interesting to see how different things in our body can affect our eye. We talked about infection, we talked about inflammation, and now we're talking about genetic conditions that can affect the inside of the eye, especially familial amyloidosis. So a little bit about it. In 10% of patients with familial amyloidosis, they can have eye manifestations. The most common being these opacities or debris within their vitreous, which is right behind your lens, which eventually turns into a cataract. This is a really good picture here, and it shows it looks cobweb-like. The pathognomonic name for this cobweb-like appearance in the eye is pseudopodia lentis, meaning white dots on the posterior surface of the lens. Other manifestations of amyloidosis in the eye can include abnormal conjunctival vessels, which are on the surface of your eye, dry eye, keratitis, which is in your cornea, glaucoma, and irregular pupillary border. So our patient, she was enrolled in the diflunisal trial, which is a treatment for amyloidosis. She had increased floaters despite being in this trial. So she actually underwent surgery. She underwent a vitrectomy for her left eye. After surgery, her vision improved significantly. And sorry, I should have put OD because OD was the one that had the significant, or her right eye had the significant floater. So before, remember, she was count fingers, so she could only see like a foot away from her face. And now she was 20/25. So that's just a case presentation of a rare syndrome or genetic condition that can occur in the eye. Again, just an example of, even in ophthalmology, although we're focusing on the eye, there's a lot of different things we have to consider systemically and go through with the patient. So just one of the reasons I love my field. So kind of back to choosing a specialty. And this is the big thing in medicine, right? You're trying to choose what you're going to do for the rest of your life. And it's a big decision. Again, for me, like I said, I started off thinking I was going to go into pediatric endocrinology because I was really interested in diabetes. What I found was I had to decide between medicine and surgery. So in my third year, during my rotations, I set it up to do surgery first and then medicine because I didn't think I'd be as interested in surgery, but I was wrong. So once I did surgery, I realized I really liked using my hands to create positive change in a patient and a patient's life to help with healing. Once I went down that route of surgery over medicine, I started looking at surgical subspecialties because you can see number 2 on my list is lifestyle. At that time, I was dating my now husband. We met in college and we were long distance for medical school. So I knew one day that we were going to get married. We actually got engaged in our third year and then married right after medical school graduation. So I knew I was going to be a wife one day. I wanted to be a mother. Again, seeing my mom grow up and be a family medicine physician, I knew that I wanted to have a family-friendly lifestyle. So looking at the surgical subspecialties, a lot of them have family-friendly lifestyles. I looked at ENT, but I realized I didn't like earwax and boogers. I know there's more to ENT than that, but Um, I I liked the ophthalmology procedures much more. Explore plastics. Plastics is really neat, the things that we're able to do with surgery. It's a much longer residency. So ophthalmology is only 3 years of residency. Again, that's not my only reason for choosing ophthalmology, but it's a consideration. So it's nice that it's such a short residency for surgery, for a surgical subspecialty. I considered urology for a minute, but there's just something about ophthalmology. I love the procedures in surgery. The surgery is finesse, cataract surgery, seeing it for the first time. I was like, wow, I want to do that. I want to do cataract surgery, take someone's cataract out and see a happy patient the next day because they can see better. I considered dermatology as well, but I can't look at acne all day. I can't look at skin all day. So again, it's important to be open-minded at first, and then when you're trying to make a decision, really try to put yourself in the place of the field or the person you're shadowing. And don't only consider their clinical life. What else do they do outside of clinic? Do they do research? Do they do community service? What's their lifestyle at home like? What are their hobbies? How are they as a whole person? So, like I said, I landed on ophthalmology for several reasons, and I actually didn't decide until mid third year. Some people might consider that late. Ophthalmology is an early match, and so you do have to get in your application by, I believe, August of your fourth year, which is like the beginning of your fourth year. My school is a small community was a small community medical school, so I didn't have much exposure to it. So again, I made my decision mid third year, and I made a pros and cons list of the specialties I was considering and kind of ruled them out one by one after shadowing. So, a little bit about my journey to ophthalmology. Like I mentioned, I came from a small community medical school that was focused on primary care. I love my medical school and it set me up really well in terms of training, but we didn't have an ophthalmology department or an ophthalmology rotation or interest group. And like I mentioned, ophthalmology is an early match. So your timeline for needing to do things for your application is a little bit shorter or a little bit quicker than some of your counterparts. So how did I overcome these obstacles? So I saw these obstacles, but I knew in my heart that I wanted to be an ophthalmologist. So I sought out mentors in my community. I just Googled, or I don't know if we really had Google search as much back then, but I asked around about ophthalmology mentors or practicing ophthalmologists in my community around my medical school. I introduced myself to them. I sent them my CV and I said, I want to apply to ophthalmology. Can I come and learn from you? I started shadowing with them, got to know them, did case reports with them, and presented at a conference. I started an ophthalmology interest group. So there wasn't a group. Okay, let's start one. And this opened up opportunities for myself for leadership and to show interest in ophthalmology, but also to form a network within my medical school because I knew there are other students like me who wanted those resources too, and who were interested in ophthalmology, but just didn't know how to make those first steps. Um, we had to do one of our medical school requirements was community service. So I started a pediatric vision screening program at an underserved school in Dayton, where my medical school was. So I saw, a requirement I needed to do for medical school, and I turned it again into a leadership position, showing initiative and showing my commitment to ophthalmology. I also, throughout my time in medical school, was involved with the free clinic of Dayton. So I started when I was a first year, and then by the time I was a third year, I was president of the free clinic volunteer board. And in having been on the other side of the admissions process, it's really important to not just do a million things just to put them on your application. It's really important to be committed and invested in the things that you're doing. They like to see that follow through and growth in participation. So like I said, I started as a member and eventually became the president of the Free Clinic of Dayton Volunteer Board. So like I said, I didn't have a home ophthalmology department. So when it came time to do away rotations, I did 3 of them, as many as I could. So I enjoyed it actually, seeing a variety of programs. I did a couple in my hometown in Cleveland, and then I did some at one at Northwestern where my husband was doing medical school. I realized what I liked and didn't like about programs. I was able to network. I was just able to see what life in ophthalmology or residency would be like. Um, it was helpful to do these aways because I ultimately ranked them lower than the one that I uh, went to. Boston University was my number one choice. But again, it was really important coming from a small community medical school to network, get my name out there, and also see what ophthalmology residency is like. So some pearls for ophthalmology residency application. This might sound silly, but proofreading. Proofreading is so important. And again, I've been on the interview side of things. So I had my dad, my fiance, now husband, and my ophthalmology mentors all read my application. Um, as for strong letters of rec, so I would say besides score, because I think the USMLE is now going to be pass fail, but besides score, strong letters of rec are can can carry a lot of weight in your application. So ophthalmology is a small field. And so getting letters of rec from prominent attendings in your field, they're probably going to know somebody that you're interviewing with. So getting to know the ophthalmology attendings that you're working with really well, showing your commitment um, it can go a long way so that they can really vouch for you. And the last point is think about your why. You are unique and you want to be in this field for unique reasons. There's only one you. So when you sit down and you fill out your application and you write your personal statement, really start with you. I mean, it's a daunting process to do the application for medical school and for residency. But again, there's only one you. You have a unique story. So find a way to communicate it, and you will do great. So now applications are done and we're on to the interviews. So same for medical school, get your application in as early as possible. Some places for ophthalmology are a rolling interview process. I did a couples match as well. So I put that in quotes because ophthalmology is an early match. And so we couldn't do the typical couples match. So ophthalmology matches in January, the typical match is in March. So my husband and I cast a wide net. He applied for radiology. And once I found out where I matched, which was at Boston University, he fortunately had a few interviews in Boston and several programs that he liked. So he ranked the Boston programs high, and that's how, and thankfully he was able to match there. So that's how we couples matched. And that's like a whole separate thing. And if you guys have questions on that later, I'm happy to answer them. So remember, once you get to the interviews for medical school or for residency, that the hardest part is behind you. That work, that dedication that you put towards those activities and research, that's the hard part. Figuring out your why, that's the hard part. And writing it on paper, now that's behind you. So you show up and try to be your best self, be confident, be courteous, and realize that the hardest part is behind you. They just want to see that you're somebody that they can work with and talk to. You can be a team player. Be prepared to talk about anything and everything on your application. So in college, going to Northwestern, it was a transition for me. I did not do that well on some of my chemistry classes and psychology classes in my first year. So in residency, somebody actually asked me, why did I get a C in psychology in undergrad? So they can ask you about anything, even as far back as college when you're applying to residency. Other things they'll ask you, how will I know you have good surgical skills? That's really hard because as a medical student, you get some exposure to surgery and you might be, tying some knots or closing up some procedures. So think about, especially if you're going into a surgical subspecialty, how can you showcase that you have good surgical skills? I think for me, I was into baking and decorating, and I still am. So I talked about my attention to detail and fine motor skills with decorating cupcakes and cookies. Why did you do research in microbiology and ortho or whatever it might be? So you might not have done research specifically in ophthalmology, especially if you were trying to figure out what you wanted to do in medical school. Even if it's not in that field, it's still very relevant. And the interviewers want to see what drove you to do that research. What did you enjoy about it? Again, it's all about commitment. You know, are you a lifelong learner? Do you ask questions? Are you curious? Um, so basically, you know, to sum up, what again, your uniqueness, what is captivating about you? And again, the hardest part's behind you, and it's just about showing it off at the interviews. So then ranking. Ranking, you're very much evaluating the programs just as much as they are interviewing and evaluating you. For surgical subspecialties, I would say the number one, at least for me, that was important was surgical numbers. You're coming out of residency, especially after 3 years, you want to be able to be as competent a surgeon as possible. And you're going to still learn in your first few years as being an attending. You're going to learn more and more about surgery techniques and what works well for you. But in residency, you want to get good surgery numbers. So where I went to Boston University, I think I got between 200 to 300 cataracts, which is really good. The ECG-ME requirement for cataract surgery is like 75 or 80, but you want the most number of surgeries that you can get. I also took 8-week maternity leave during my third year of residency when I had my first child, and that's when you get your cataract surgery numbers. So the sign of a strong program is still being able to do maternity leave and get good surgery numbers. And it's not just about cataract surgery. You want to see, okay, are you getting exposure to all the subspecialties in ophthalmology? Are you getting glaucoma surgeries, cataract surgeries? Oculoplastics, retina surgeries, lasers in clinic, which is another big thing in ophthalmology, in-office lasers and injections. So looking at the surgical breadth and diversity is important. I made another pros and cons list for each program after each interview. Important points for me were couples matching potential. So like I said, we cast a wide net and we tried to interview and rank programs where there were multiple options for both of us. Surgical numbers, learning environment was really important to me. So I do best in non-toxic, non-high stress environments. Not to say that parts of residency certainly were tough and that, you know, with challenges comes a lot of learning. But what I looked for was approachable faculty. I also looked for attending mixtures. So um, you know, having female mentors was really important to me, especially in a surgical subspecialty, but also seeing the generations, you know, so there, I saw there were young and older attendings, and even within the residents, are the residents happy? Um, and I saw that there were a mixture of residents. Some were single, some were married, some had kids. Some wanted to do fellowship, some wanted to do general ophthalmology. So that was really important to me. It was how inviting of an environment did it seem? Could I learn there well? Patient demographic. So one thing I liked about my program that I ended up matching at was there was a lot of diversity in the patient population, which also means a lots of pathology. Boston University Medical Center is a safety net hospital. And so I saw patients, unfortunately, with previously poor access to care. But then I also saw a lot of pathology. I saw patients from all over the world. And then I also got to do outpatient clinics with more bread and butter things in ophthalmology. It was also important for me to see where are graduates now. So are they general ophthalmologists? Are they in fellowship? You know, what are the products of this residency program? And then again, this might sound superficial, but looking at the clinical resources. So when I saw my residency program that I matched at, the clinic was beautiful. You're going to be going into this clinic every day. You want to like where you're working. So Boston was really cool. The clinic beautiful, really great resources and technology. Ophthalmology is one of those fields that the technology is growing at a fast pace. And so you want to be at a program that has access to new technology. Less important to me was the amount of research I had to do. I am not super into research, so I didn't have to, go to a really research heavy program. And then academic rank wasn't as important to me. Again, I was just looking for a good learning environment for myself. So a day in the life of an ophthalmology attending, I would say residency, lifestyle in residency is very different than lifestyle once you're done with training. Residency is a huge learning curve. So once you're in ophthalmology attending, things with life get much more easier in a sense. So for me, I work part-time. So I work 3.5 days a week, half day Fridays, and I work 2 half Saturdays a year. So really not much weekend commitment. I'm off most holidays unless I'm on call. I'm on call 2 holidays a year. I'm on call about 1 week a month, but it's extremely rare, at least where I'm located in my practice, to have maybe a phone call at night, but extremely rare to go in. I go in maybe once or twice a year for like an eye emergency, like an open globe, which is where you have to go in emergently to the operating room to close an eye after a severe trauma. So again, that was one of the big reasons I chose ophthalmology, because really low weekends, you can be part-time, which is nice, and really low emergencies. This is for you guys. You can click on this link later. It's basically to watch what a typical cataract surgery looks like. So what do I actually do in clinic? So in clinic days, I see a mix of things. So I'm a retina specialist, so I see retina consults. So that involves seeing diabetic retinopathy, macular degeneration, retinal tears that I need laser. I also see cataract evaluations, so I do cataract surgery. So those are surgical evaluations to look at measurements and see if a patient qualifies for surgery. I see glaucoma, which is a silent optic nerve problem in the eye. Usually we start with drops and then we move on to laser treatment and sometimes surgery. I also see a lot of dry eye, especially this time of year with the winter. I get to do a lot of in-office procedures, which is one of the things that I loved about ophthalmology. So I do a lot of intravitreal injections, and down below is a picture of someone getting prepped for an intravitreal injection. I treat diabetic retinopathy and macular degeneration most commonly with the injections. I do different types of lasers. So up top is a picture of me with my laser in clinic. So I do glaucoma lasers to lower eye pressure. I do YAG capsulotomies. So after cataract surgery, you can develop something called a secondary cataract, which is just a little film behind the lens. And patients come in thinking that their cataract's growing back and they can't see as well. You do this laser in clinic, it takes about 5 minutes and they see really well, like within a few minutes, hours, or the next day. So it's a really satisfying laser to do. I also do retina lasers. So again, lasers for retinal tears, lasers for diabetes, many reasons to do laser. Surgery day. So there's lots of different surgeries ophthalmologists can do. I focus on cataract surgery. And again, I hope you guys later can take a look at that link for the other YouTube video. Cataract surgery, it's just so neat. It's like this rock in the eye, and you take it out with surgery, microsurgery, and the next day, usually they're already seeing better. So that's the last part of this. Best part of seeing my patients is that they're usually very happy after surgery. And so seeing quick procedures, quick surgeries that make patients happy, that's one of the big things that drew me to ophthalmology. This is a video of an intravitreal injection. Again, you guys can watch it on your own later, but again, just one of the typical procedures I do in clinic. So what can I do to set myself up for success? So we talked a little bit about these, but number one, be open-minded. Be open-minded to opportunities. As you can see from my journey, I thought I was going to be a pediatric endocrinologist, and now I'm a cataract surgeon and retina specialist. So be open to the opportunities that are presented to you or that you happen to stumble upon, or in research. Like I said, I happen to fall into this diabetic retinopathy lab, and now I'm treating diabetic retinopathy. Be open to clinical opportunities, shadowing opportunities. The more specialties you can see, the better informed you'll be when you're trying to make a decision about what type of doctor you want to be when you graduate. Be open to extracurricular activities. You don't know what sorts of avenues they'll lead you toward. Network and connect with mentors, and mentors can look different for everyone. They can look like an older, someone more senior to you in medical school to kind of mentor you through how they chose their specialty, or mentor you through how to get through these tests or this certain class or practical. They can look like research mentors. They can look like doctors in the community who you shadow. So mentors can come in all different forms. Get involved and show commitment in the areas you're passionate about. Your passion and dedication will shine through, and they will be authentic when you interview. Again, that's the hard part, is figuring out your why and then focusing on that why and doing research or extracurriculars and getting involved in things associated with your why. And then that's the hard part of your application, right? Study hard. So there is no replacement for studying for tests. Tests and scores are unfortunately part of life in school, but the work ethic that you develop when you study for this test is going to set you up for success in medicine, in life. I had to take so many tests, MCAT, step 1, tests, board certification in ophthalmology and oral boards. So tests are just part of life. But find what works for you and then use those, find a routine, and it'll carry through. And then have fun. College and medical school were the best times of my life. I have the best of friends from those times, and in a sense, your main responsibility for most people, and everybody's life situation is different, is studying for school and making those connections and having friends. Now I'm older, right, and have kids and responsibilities like taking care of a house and cooking and cleaning, all that other stuff. But definitely have fun in medical school. So getting close to the end of my talk here. So I did want to touch on what challenges I face as a female in medicine, because being a female, you certainly do, we face challenges. We know that. And so one important thing to me, as you remember when I was looking for residency, was to find female mentors. So I loved that my program director was a woman, and there were several. Retina is a male-dominated specialty, and there were many women in retina in our department. And so that's what showed me, okay, these women can do it, so can I. You can have a baby. So that's the big part of being a female in medicine, right? Like, we're at this age where we're childbearing and we're thinking about starting a family, and you can do it. So I had my first child in residency, my 3rd year of residency. I was super nauseous and super nervous about trying to learn how to do cataract surgery. I let my mentors and attendings know. I let my program director know. And I got through it. I got through it with really good numbers. I still learned how to do cataract surgery really well. And I still enjoyed being a mother. It's really busy when you're a resident. Having had my second child as an attending, 2 very different experiences. This is a picture of me in Nantucket, enjoying a weekend getaway with my husband, my daughter, and our dog. So one of the fun parts of living in Boston was taking advantage of the weekends that we were off or weren't on call. So we did that, and we could still do that even in medicine, even both of us being in medicine. Being a female surgeon, what biases do you face? And I would have to say I was pretty lucky as a resident, because there were so many other female residents and female attendings that I didn't feel in the OR different pressures. In terms of being a surgeon, I thought, am I the surgeon type? And what does that really mean these days? So that was kind of an internal bias I had. Would I be good at surgery? Going back to that interview question when I was a resident. I don't think I had naturally gifted hands. In fact, I'd be so nervous. Sometimes my hands would shake under the microscope. But I had patient and good attendings who taught me to kind of do breathing techniques, fellows also. Um, and I got over it. And again, I'm a proficient surgeon now. So just goes to show you that even if you don't think you're the surgeon type, or if you don't think you have good hands, that you can practice, 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 and you will be able to do what you want to do. So I think this is my last slide, but again, why choose ophthalmology? So just to summarize, it's a surgical subspecialty. So if you want to use your hands and you're thinking about surgery, that's the route I went. It has a good lifestyle, happy patients for the most part. You're helping people with their vision. That's huge. That's one of our most important senses. Evolving technology. So like I said, ophthalmology has a lot of technology we use to treat the eye, and it's growing. Good compensation. So as you notice, I didn't talk a lot about compensation because money is important, but it's not everything. But I do believe ophthalmologists are happy because we get good compensation for the amount of procedures and surgeries that we get to do. That being said, CMS or Medicare do make cuts almost every year to almost every surgical subspecialty. So unfortunately, that's an uphill battle, and something you'll face more and more when you're an attending. So for the most part, I would say good compensation. Ophthalmology is only 4 years, so 1 year of internship, 3 years of residency, and then 1 to 2 years of fellowship if you wish to. I would say out of our program, about 50% of doctors are general ophthalmologists, so you don't have to do a fellowship, and about 50% chose to do a fellowship. There's a variety of fellowships. There's retina, which is medical and surgical. I did medical retina, which is only a 1 year fellowship. Glaucoma, cataract, refractive, which is like LASIK surgery, oculoplastics, pediatrics, neuro-ophthalmology, and uveitis. So there's a whole variety of specialties, even within ophthalmology. Even though you're focused on one part of the body and it's a small organ, there's a lot of intricate details and pathologies that can be associated with it. Why not ophthalmology? So hard to think of any reasons because I'm biased since I'm an ophthalmologist. Like I mentioned, Medicare is continuing to decrease reimbursements for procedures across many surgical fields, not just ophthalmology. So that's not a con for ophthalmology in general, but just something to be aware of. It is a hard name to spell, but eventually you'll learn how to spell it. And then when you see it spelled incorrectly, it really bugs you. So thank you guys. This is just my contact information. One of my hobbies after being done with fellowship was to start my social media page. So I've loved connecting with a lot of you, and I love hearing back from you, but this is my contact information on Instagram, TikTok, Twitter, and my email as well. Any questions I can answer?
Thank you so much, Dr. Shanika. We do have some questions on YouTube.
Okay.
So the first question we have is, what would be considered a high eye pressure for someone below 18 that has to be diagnosed with glaucoma?
So a high eye pressure, and for every patient, it's going to be different. So it depends on, like I said, average is 21 or less, even if you're under 18. You have to look at their cup to disc size. So in someone who has glaucoma and their cup to disc ratio, so I would say average is 0.3. If you have a 0.5 cup to disc, for example, your the pressure that you want your ideal IOP or goal at will be different from a patient who has like a 0.9 or really cupped out cup to disc. So you might want theirs a lot lower. So again, it depends on the patient. And regardless of age, we're still looking at 21 or less, depending on how their optic nerve looks.
What is the clinical difference between an optometrist and ophthalmologist? Do they perform the same type of eye exam?
So that's a really good question, and actually something I didn't really know much about until I was in residency. So an optometrist, that is a eye doctor who does not perform surgeries and procedures. So They are focused on eye exams, contact lenses, glasses, less of the medical surgical part of eye care. I work very closely with optometrists, and their training is very different from an ophthalmologist. So optometry, I think you can go into optometry right out of college, but I may be incorrect. Um, Ophthalmology, you have to do a medical degree, MD or DO, and we deal a lot more with the medical and surgical aspects of eye care. So like lasers and procedures all have to be done by an ophthalmologist.
As a high schooler, especially during the pandemic, what do you recommend for high school students to do in order to gain experience about the field of medicine?
That's a good question. And I can't imagine how hard it is, how much we're all pivoting, and especially when you're trying to learn and get exposure and meet people and network, right? So I think doing sessions like this and getting exposure to a wide variety of fields is really important. And then look within your community. See if you can connect with mentors that are local. With an email, see if they could, do an online chat, or if you can ask questions through email. I know shadowing in person can vary, and I think right now we're in the height of the pandemic, and so that's really tough to shadow. Um, I would say just contact your local physicians and see what they're able to do. Or I'm hoping in the next few months things get easier to shadow as well.
Could you explain the residency application and matching process a bit more?
Sure. So everybody's residency application process is a little different depending on what specialty you're applying for. Like I said, for ophthalmology, it's an early match. And so usually it's in your fourth year, in August of your fourth year, that you have to submit your application and your letters of rec. I believe you need 3 letters of rec for ophthalmology, but that could be different now. At least one of them from an ophthalmologist, 1 or 2 of them, but then one of them has to be from a different specialty. So that's why it's important to get to know mentors of all, from all different specialties that you connect with. After you apply, you wait and you hear for interviews. And once you get interviews, that's the whole interview process. Matching, once you've done your interviews, then you can rank those. Ranking is on a computer system. And, like I said, kind of prioritize what's important to you in terms of where you'd like to match. So I would say focus on what you want, not what you think the programs will rank you. Usually the match process works in your favor as the applicant. And sorry, what else was part of that question? I forget if I went off on a tangent if I was answering all of it.
They're wondering how the matching process works
How it works.
and how do you
So,
get into your top residency as well?
gotcha. So, exactly. So the matching process, it works usually in your favor. I mean, there is a chance, especially in competitive fields like ophthalmology, that you might not match. The numbers were different when I applied years ago, but I think there was like a 10% maybe rate where you could go unmatched. So again, it's once you get those interviews, then you can rank all of them if you wish to. You don't, if there's a program that you don't like, that you absolutely don't want to be at, I would not rank it. And then it's like an algorithm in a computer system, and so the programs submit their ranking of all the applicants they interviewed. You submit the ranking of all the places you interviewed at, and then they try to match up, as high on your list and as high on the program's list. And again, usually works out in your favor. In terms of matching at your top ophthalmology program, it's really about, like I said, putting in that hard work. So you have to be proud of your application once you apply. So it's all those preclinical years before applying to residency, working hard to, get good letters of rec, good grades, or, like I said, I didn't have perfect grades, but doing the best you can, getting involved. And then interviewing. You want to make connections and show who you are, show that you're someone that they can converse with, and that you're a team player. It's really important to be courteous to everybody on your interview day, because you don't know who is involved in the rank process. it's important to be courteous to the coordinator and everybody you meet, janitors. They want to see that you're a good person overall and a good team player. Again, things might be different this year because everything's virtual, I think, again, this year. In terms of matching at your top program, afterwards, I would email them and let them know your intentions. So once I narrowed down, like a few weeks before having to turn my application in, once I'd chosen Boston University as my number one, I emailed them and I told them, I was very straightforward, that you are my number one. This is why I want to be at your program. This is why I think I'd be a good fit for your program. I emailed my number 2 and 3 and said that they were in the top of my list. So I only told one program that they were number one. Again, you have to be straightforward with them. I didn't get any emails saying you were ranked to match, and frankly, I think that's illegal, and I don't know if people still do that these days. But letting your number one program know, number 1, 2, and 3, that you're very interested in them, I think goes a long way.
Did you do any internships or shadow a doctor when you were in high school?
In high school, I did shadow a variety of doctors. I shadowed, I think, a plastic surgeon. I shadowed an ophthalmologist at one point, shadowed a pediatrician. But then also in medical school, with your rotations, you see a variety of different fields and in a variety of settings, right? Hospital and outpatient. So in high school, I didn't really do an internship, but I did do some shadowing.
Have people switched what residency program they are in, or is it a final choice when applying to programs?
Definitely. I have heard of folks switching residency programs. I've heard of ophthalmologists going to dermatology programs. I've heard of, radiologists going to medicine programs. I've heard many different types of transitions. And so it's definitely not the common way to go to residency. But if for whatever reason, when you start residency and you realize that this is really not the field for you, then it's important to find resources and figure out what you want to do and apply. So that is possible. I would say try to do everything you can to figure out your why, figure out what your values are, what you like in medicine, and try to find a specialty that matches up to that. But again, real life happens, right? And then once you're in a specialty, you might realize, wow, this really isn't for me. I would say ophthalmology is tough. The first 6 months are really tough. There were points where I was like, is this for me? Is this really what I want to do? Just because the learning curve is so steep and there's so much pathology and pressure because you're on call to, you don't want to miss something. But again, it goes back to the strength of your program and the resources and support they have, especially from senior residents, and helping you, and mentors helping you in those first 3 to 6 months in residency.
So the last question would be, what tips would you give to students as they transition into college? What are some ways for them to get involved?
So it depends on what interests you, but I would say that getting involved in some capacity is really important even when you're going to college. So I got involved in research, was one kind of foot in the door that opened a lot of opportunities. So I did it locally where I lived, not so much where I went to college. And then the summers between years in college, I would come back home and continue to work in the same lab. So I worked in the same lab for like 6 summers. So I got, to know the lab well. I got to know the work well. I presented, wrote a lot, and worked with those mentors a lot so they could really vouch for me when I was applying for medical school and even when I was applying for college. And so, it doesn't have to be research. It could be a volunteer opportunity at a soup kitchen, starting there and getting to know people and then working your way up in leadership. It could be working, at a hospital volunteer program. Just, find something that clicks with you, and if you can, stay with it to show commitment.
Thank you, Dr. Shanika, for joining us today and teaching us about ophthalmology. It was truly a wonderful presentation. For those watching this, the link to the quiz will be posted on our link tree found in the Instagram bio, and our Instagram ID is way_organization. So please make sure to have a look at that. Within this week, we'll also be emailing you your certificate, so please make sure to look for that as well. Thank you once again.